Hey guys, welcome and welcome back to my channel. This is Dr. Prasanjit, currently GR2 in the Department of Pharmacology, AIMS Kalyani, and today I am back with one of my videos. So this video is targeted for the BSc nursing students. So without wasting any time further, let's get into today's topic. So in today's video, I will be taking the class on treatment of shock, plasma expanders and IV fluids, and this is basically catering the BSc nursing students. So in today's video, our specific learning objectives will be to know what is shock and its management, then about plasma expanders, a part of which is the intravenous fluids. So a special mention about the intravenous fluids also, IV fluids, that is intravenous fluids. So what is shock? So let's discuss what is shock. So shock occurs when the rate of arterial blood flow is inadequate to meet the tissue metabolic needs. That is, the arterial blood flow is inadequate to meet the metabolic needs of the tissue. And as a result, what happens is there occurs regional hypoxia because oxygen is not reaching the tissue, and because oxygen is not reaching there, so the tissues will start doing anaerobic metabolism, and because of this there is production of lactic acid. So it leads to subsequent lactic acidosis in the peripheral tissues, and it will eventually lead to end organ damage and failure. So this is what we call shock. So shock is basically when the rate of arterial blood flow is inadequate to meet the tissue metabolic needs, and as a result it leads to hypoxia, and because of hypoxia the tissue starts metabolizing in the anaerobic way, leading to the production of the lactic acid, which causes lactic acidosis, and also finally there is end organ damage and failure. Now coming to the classification of the shock. So shock is classified into four types, that is hypovolemic shock, cardiogenic shock, obstructive shock and distributive shock. So we will be discussing all these type of shocks in the upcoming slides. So coming to hypovolemic shock, so in simple terms, hypovolemic shock means hypovolemia, that is decrease in the volume of the circulating blood. So that is what we can say in simple terms. So this leads to shock. As a result, there is decreased oxygen delivery to the tissues, leading to hypoxia and then finally lactic acidosis. So hypovolemic shock results from the decreased intravascular volume, which can be secondary to the loss of blood or fluids and electrolytes. So it can be either due to the loss of blood or it can be due to the loss of fluid and electrolytes. So let's see the etiology. So it can be due to trauma, that is there can be loss of blood, or it can be due to some non-traumatic causes of loss of blood like the GI bleeding. And on the other hand, we are having the loss of fluids and electrolytes. So it can happen in the form of dehydration, that is by vomiting or by diarrhea. So these are the different reasons for hypovolemic shock. So hypovolemic shock can be due to the loss of blood, or it can be due to the loss of fluid and electrolytes. So for the loss of blood, it can be traumatic and it can be non-traumatic. So if there is trauma, it can lead to the blood loss, and sometimes it can be just bleeding without any non-traumatic reasons, that is like in case of GI bleeding. Then the loss of fluid and electrolytes, that is occurring because of dehydration, which can be due to the following reasons like the diarrhea and vomiting. Now what happens after this? So after this there is compensatory vasoconstriction, and this can transiently maintain the blood pressure because already there is a decrease in the blood volume. So as a result, as a compensation, the blood vessel constricts. So this leads to the maintenance of the blood pressure, but unreplaced losses over more than 15%, that is more than 50% of the intravascular volume, can lead to finally hypotension and progressive tissue hypoxia. So this compensatory mechanism will work for a short duration only, and if the loss of the blood volume is more than 15% of the total volume, then in that case it will manifest in the form of hypotension, that is decreased BP, and no longer the vasoconstriction will be able to maintain the blood pressure. Now moving on to the next type, that is the cardiogenic shock. So cardiogenic shock results from the cardiac failure, that is inability of the heart to maintain adequate tissue perfusion. So that is what we call as cardiogenic shock. So it can be due to several reasons. It can be due to myocardial infarction. As you can see, the clinical definition of cardiogenic shock is the evidence of tissue hypoxia due to decreased cardiac output in the presence of adequate intravascular volume. So if there is a decrease in intravascular volume, then it will come in the hypovolemic shock. So in case of cardiogenic shock, the intravascular volume remains normal, but there is decreased cardiac output, which is the reason for the shock. And this is most often caused by MI, that is myocardial infarction, because it damages the myocardium. But it can be also due to some other causes like cardiomyopathy, it can be due to myocardial contusion, it can be due to valvular incompetence or stenosis. As a result, there can be regurgitation, there can be decreased flow of the blood from the heart. So all these reasons and arrhythmias, because of which there is decreased release of the blood, that is decreased cardiac output, and as a result, all these leads to cardiogenic shock. So this is the second variety. Now let's discuss the third variety, that is the distributive shock. So distributive shock is also called as the vasodilatory shock. So it can be due to the following reasons like sepsis, that is infection, it can be due to anaphylaxis, it can be due to traumatic spinal cord injury, or it can be due to some endocrine reasons like acute adrenal insufficiency. So here there will be a reduction in the systemic vascular resistance, which leads to tissue hypoperfusion despite the normal circulatory volume. So what happens is, here there will be vasodilatation, and because of this vasodilation there will be decrease in the systemic vascular resistance. So this leads to tissue hypoperfusion, and there are different reasons. It includes sepsis, anaphylaxis, then traumatic spinal injury, then it can be endocrine causes like acute adrenal insufficiency. So that is the reason why we are having the different types of distributive shock, that is septic shock, then we have anaphylactic shock, then we have neurogenic shock, that is basically due to the injury to the spinal cord, then endocrine shock, that is mainly because of acute adrenal insufficiency. So these are the reasons, that is, these are the different types of distributive shock. Now let's move on to the different types of distributive shock. First is septic shock. So sepsis, that is basically infection, is the most common cause of the distributive shock. Then the most common cause of septic shock in hospitalized patients is infection with the gram positive or the gram negative organisms. Then coming to the next variety, that is anaphylactic shock. So it is a severe type 1 hypersensitivity reaction, and it is basically IgE mediated and occurs in response to triggers like drugs like penicillin, insect bites. So it is basically anaphylaxis. And here the features will include sudden onset of flushing, then there can be angioedema, there can be respiratory distress, hypotension, vomiting, abdominal pain, and finally the cardiovascular collapse. So these are the features of anaphylactic shock. That is, anaphylactic shock is basically a type 1 hypersensitivity reaction which is IgE mediated, and it can be triggered by several allergens. It can be as a response to some of the drugs like penicillin, it can be due to insect bite. So this is the another variety of distributive shock. So here we have seen two types of distributive shock, that is septic shock, and then we have the anaphylactic shock. Then coming to the next two types of distributive shock. First is the neurogenic shock, and then we have the endocrine shock. So neurogenic shock. Neurogenic shock is caused by traumatic spinal cord injury. So it can be also during the process of epidural or spinal anesthesia. So because of that, that can be injury to the spinal cord, and as a result that can also lead to neurogenic shock. So the result of neurogenic shock is the loss of sympathetic tone. As a result, there will be reduction in the systemic vascular resistance, and hence hypotension will occur. And since the spinal cord is being injured, so there will be no compensatory tachycardia. So it is the case of hypotension with no compensatory tachycardia, because normally when the BP decreases by reflex, it will increase the heart rate, that is reflex tachycardia. But in case of this neurogenic shock, there will be decrease in BP but no reflex tachycardia. Then we come to the next variety, that is endocrine shock. So it can arise from hyper or hypothyroidism, or the most common cause is acute adrenal insufficiency. So So adrenal insufficiency most often occurs when we do the abrupt stoppage of the long-term corticosteroid. As a result, because the person was given corticosteroids, so the adrenal glands have stopped producing the corticosteroids. And when we stop it suddenly, this will lead to the precipitation of the adrenal insufficiency, which is manifested as endocrine shock, and it can be also precipitated by other factors like infection, trauma, surgery, or any pituitary injury that can also lead to endocrine shock. So these are the four varieties of distributive shock, that is septic shock, then we have anaphylactic shock, then we have neurogenic shock, then we have endocrine shock. Now, coming to the classification of shock, which we have already discussed, and the different causes, the common causes which leads to this. So first, hypovolemic shock, as you can see, it can be due to blood loss or it can be due to volume loss. So blood loss can be either traumatic hemorrhage or it can be non-traumatic hemorrhage. So under traumatic hemorrhage, we have hemothorax, that is presence of the blood in the thorax. Then we have hemoperitoneum, that is presence of the blood in peritoneum, and then fracture. It can also lead to loss of blood, that is, it can lead to bleeding. Then we have non-traumatic hemorrhage. Under that we have GI bleed. Then we have abdominal aortic aneurysm rupture, or we can also have ectopic pregnancy rupture. Then volume loss, that is the loss of fluid and electrolytes. So in that case, what are the reasons? First we have burns, then we have vomiting, then we have diarrhea, then we have third spacing, that is basically ascites and pancreatitis. So in these cases, we will get fluid, loss of fluid and electrolytes. So that will also lead to hypovolemic shock. So these are the common causes of hypovolemic shock. Now coming to the next category, that is the cardiogenic shock. So it can be due to these arrhythmias, which includes bradycardias and blocks. As a result, as you can see, when there is bradycardia or block, the heart will stop pumping. In case of block in bradycardia, it will be pumping slowly, so it will not meet the metabolic demand of the tissues. Or else it can be tachycardia, that it takes such a short duration of time to beat that only a very little amount of blood is coming out of the heart. So this will also lead to cardiogenic shock. Then in case of myocardial diseases like left or right ventricular infarction, that is myocardial infarction basically, then we can have dilated cardiomyopathy. Then mechanical, under that we are having valvular problems like acute valvular rupture. Then we can have ventricular septum rupture, ventricular free valve rupture. So these are the causes for cardiogenic shock. Then we have obstructive shock. From the name itself, it is clear that it is obstructing the flow of blood out of the heart. So it can occur in case of tension pneumothorax, when there is a increase in the pressure within the thoracic cavity due to trauma to the thorax. Then it can be in cases of pericardial diseases like pericardial tamponade or constrictive pericarditis. Also, we have other conditions where there is obstruction, that is in case of pulmonary embolism. If it is a massive pulmonary embolism, then it will also stop the flow of blood from the heart. Then we have severe pulmonary hypertension, which will also restrict the flow of blood out of the heart. So all these things will lead to obstructive shock. Then we have the distributive shock. As I have already mentioned, it is mainly due to anaphylaxis, sepsis, then due to the traumatic spinal cord injury, or it can be due to the endocrine factors, that is acute adrenal insufficiency, hypothyroidism, or hyperthyroidism, and it can be also due to drug induced vasodilation. So these are the common reasons for vasodilatory or distributive shock. So these are the different types of shock and their common causes which is leading to these type of shock. Now let's discuss about the symptoms and signs of different types of shock. As you can see here, I have classified the shock under the following headings. So we have anaphylactic shock, then we have cardiogenic shock, then we have hypovolemic shock, then we have obstructive shock, neurogenic shock, and septic shock. So anaphylactic shock, and then we have the neurogenic shock, and then we have the septic shock. So all these come under the distributed type of shock. Then we have obstructive type of shock, then we have hypovolemic shock and cardiogenic shock. So in case of anaphylactic shock, the respiratory rate can either increase or decrease, heart rate will increase, BP will decrease. Why? Because there is vasodilation, so there is a decrease in the blood pressure, and the skin will be flushed, swollen, and itchy, because it is an IgE mediated reaction, and so there will be degranulation of the mast cells, leading to the release of histamine, which causes vasodilation, leading to the flushing of the skin, and it will also lead to pruritus, that is itching. Then the temperature, it remains almost normal, and the urine output decreases here. Then other features which occurs here is pruritus, as you can see. Then there is bronchoconstriction, Then on the other hand, we have the cardiogenic shock where there is increase in the respiratory rate, increase in the heart rate, but the BP falls because the heart is not able to pump enough amount of blood. So here we will get pale, cool, clammy extremities. Then here also the urine output will decrease. There will be no change in temperature. Apart from this, since there is obstruction to the flow of the blood out of the heart, as a result, this will lead to jugular venous distension. So jugular veins will be dilated in this case, and it can also lead to pulmonary edema and orthopnea. Then we have hypovolemic shock. Here there will be increase in the respiratory rate, heart rate will increase because there is decrease in the blood volume. Then BP will fall because there is decrease in the blood volume. Then the extremities, that is skin, will be pale, cool and clammy. Here also that there won't be much temperature change. Here the person will have thirst, or the person can later on have confusion, then syncope and dizziness. Then we have obstructive shock. Here there is increase in the respiratory rate, increase in the heart rate, but decrease in the blood pressure. So here the extremities, the skin in the extremities will be pale and cool. And here the temperature will also decrease because it is obstructive type of shock. So blood will not be able to come out of the heart. And the urine output will decrease in both the cases. Here, in case of pericardial tamponade, suppose if pericardial tamponade can be one of the reasons of obstructive shock. In that case, we will get muffled heart sounds because heart, that is the myocardium, is being covered by a layer of blood outside it, and then there will be dilatation of the jugular veins, and there will be signs of poor perfusion also. Then we have neurogenic shock. Here there will be increase in the respiratory rate, heart rate will fall, and BP will also fall. That is, hypotension occurs because of the vasodilation, but there is no reflex tachycardia because of the injury to the spinal cord. So here also we will get warm, flush, dry skin, and the temperature can either increase or decrease. And coming to the urine output, there will be no bladder control on the urine output because the spinal cord is injured, so there will be no control on the bladder. Then there will be paralysis distal to the site of injury of the spinal cord and can be also seen, and it can also manifest in the form of priapism, that is basically the painful erection of the penis. Then coming to septic shock, here there will be increase in the respiratory rate, there will be increase in the heart rate, but decrease in the BP because of the vasodilatation. Then the skin will be flushed, and then it will become pale and cool. So here the temperature can be either more than equal to 38 degrees Celsius, or it can be less than 36 degrees Celsius. Urine output will increase, and in case of septic shock we can get bounding pulse also. So these are the features of the different types of shock, that is signs and symptoms of different types of shock. Now let's discuss about the management of the shock. So whenever we are discussing about the management of any type of shock, so it will include general measures, then the hemodynamic measurements which we do as we keep on managing the shock, then the volume replacement in case where we need the volume replacement, then the medications and the other treatment modalities which can be used for management of shock. So first, let's discuss about the general measures. So it is applicable for almost all the types of shocks. So initial management consists of basic life support, where we are going to assess the patient's airway, breathing and circulation, and if required we will be doing intubation and mechanical ventilation also. That is basically providing oxygen to the patient also. Then we will gain the intravenous access, and we will start the fluid resuscitation along with cardiac monitoring and assessment of the hemodynamic parameters such as the blood pressure and the heart rate. This is because we need to monitor continuously as we do the fluid resuscitation of the patients. Then cardiac monitoring can also help us to detect myocardial ischemia or any malignant arrhythmias, which will be managed by advanced cardiac life support. So these are the first two steps which are seen in case of general measures. Then continuing with the general measures, if the patient is unresponsive or minimally responsive, then in that case we need to check the glucose of the patient. So if their glucose levels are low, then one ampule of 50% dextrose will immediately improve the condition of the patient. Then it is given intravenously, so it can be due to the loss of glucose. Then an arterial line should be placed for continuous blood pressure monitoring. So it is basically to measure the mean arterial pressure, and an indwelling catheter, urinary catheter, has to be introduced so as to monitor the urine output every now and then. And then continuous monitoring of all the vitals is to be done, that is the heart rate, respiratory rate, blood pressure, and if possible we can also connect the patient to several ECG leads so that we can continuously monitor the rhythm and the different waveforms also. So this is about the general measures. Now let's discuss about the hemodynamic measurements which are being done when we are managing the patient of shock. So early consideration is given for the placement of the central venous catheter, that is CVC, as you can see here, central venous catheter, which is also known as the central line. This is because it helps in infusion of the fluids and also the medications and for doing the hemodynamic pressure measurements. So a CVC can provide the measurement of the central venous pressure and also the central venous oxygen saturation, both of which is to be monitored in case of management of septic shock and cardiogenic shock. So a CVP which is less than 5 mmHg suggests hypovolemia, that is hypovolemic shock, and a CVP greater than 18 mmHg suggests volume overload. So suppose if we are treating hypovolemic shock by intravenous fluids, then it leads to high volume overload. Then it can be easily noticed with the help of the central venous pressure when it is more than 18 mmHg. So it suggests either volume overload, or it can also suggest cardiac failure, cardiac tamponade, that is pericardial tamponade, or pulmonary hypertension. Then we can do transthoracic echocardiogram, which will provide us information about the pulmonary artery pressure and current cardiac function, including the cardiac output. And also point of care ultrasound measurements of the inferior vena cava helps us to identify the amount of intravascular volume and whether it requires any fluid replacement or not. So when we do the point of care ultrasound, the measurement of the inferior vena cava, then we will get an idea whether we have to do the fluid replacement for the management of hypovolemia or not. Now coming to the third part, that is the volume replacement. So it is required in case of hemorrhagic shock. So in hemorrhagic shock, it can be in the form of O negative PRBC, that is packed red blood cells, or it can be O negative whole blood. In case of hypovolemic shock, also we can give the blood products, but there also we can give intravenous fluids also. Then it is also given in case of cardiogenic shock in the absence of any fluid overload. Suppose if there is a cardiogenic shock and there is fluid overload, then in that case we are not going to give the volume replacement. Then also in case of septic shock we are going to do the volume replacement. So the choice of resuscitation fluid, in most of the cases we are preferring the crystalloid solutions, examples being normal saline and ringer lactate. So these are the two most commonly used resuscitation fluid for the volume replacement, which is done in different types of shock. Now coming to the fourth category, that is usage of medication. So under medications we are having several category of medications. So first we have the vasoactive therapy. So it is basically giving vasopressors and inotropic agents. So vasopressor is basically the ones which constrict the blood vessels, and as a result it increases the blood pressure, and inotropic agents helps in increasing the contractility of the myocardium. So they are to be given only after adequate fluid resuscitation is being done, not before that. So if there is continued hypotension with evidence of high cardiac output after adequate volume resuscitation, as in case of septic shock, then vasopressor support is needed to improve the vasomotor tone. So if there is evidence of low cardiac output with high filling pressures, then in that case what we will do, we will not give the vasopressor, but in that case we are going to give the inotropic support so as to increase the contractility of the heart. So epinephrine is usually the vasopressor of choice for anaphylactic shock, and other vasopressors which can be used includes norepinephrine or noradrenaline, or we can also use phenylephrine. Then vasopressin, that is antidiuretic hormone, is used as an adjunctive therapy to these catecholamine vasopressors when the individual is not responding to the vasopressors like epinephrine or norepinephrine or phenylephrine. Then suppose if the individual is not even responding to this combination, that is epinephrine or norepinephrine or phenylephrine plus vasopressin, in that case we will give angiotensin 2. So a brand name for angiotensin 2 is Giapreza, and it can be considered, that is, in as an additional agent in vasodilatory shock when it is refractory to both catecholamines and vasopressin. So suppose we are getting this vasodilatory shock. So in that case what we are going to do is, first we will give the fluid resuscitation. After that we are going to give the vasopressors. So if there is no response to vasopressors, then to that vasopressors we are going to add ADH, that is vasopressin. And suppose if there is no response to this combination also, then to this we are also going to add angiotensin 2. So angiotensin 2 is used in case of the refractory shock, that is refractory to both vasopressors and vasopressin, that is antidiuretic hormone. Now coming to the next category, that is antibiotics. So antibiotics are basically the definitive therapy for septic shock. So it has to be started as early as possible. That is, we are going to start with empirical broad spectrum antibiotics only after obtaining the samples for cultures. That is, after the samples are obtained for the blood culture, then what we are going to do is we are going to do the culture in hypersensitivity, and then we are going to shift to the more specific antibiotics. Then we can use corticosteroids, which are the treatment of choice in patients with shock where it is secondary to the acute adrenal insufficiency. So we are basically supplementing the corticosteroids from outside, which is lacking in case of adrenal insufficiency. Then continuing with the other treatment modalities, so coronary artery bypass surgery, that is CABG, that is coronary artery bypass grafting, appears to improve the long-term outcome with increased survival compared with initial medical stabilization for the patients with myocardial ischemia leading to cardiogenic shock. So if the cardiogenic shock is due to myocardial ischemia, then one of the treatment modalities can be also coronary artery bypass grafting. Now let's discuss about the workflow of management of different types of shock. So we are going to discuss specific management for different types of shock. So under this, first we have the hypovolemic shock management. So in this we are going to do first fluid replacement is done. Most commonly used is normal saline, that is 0.9% sodium chloride, and it is the mainstay for non-hemorrhagic type of hypovolemic shock. And in case of hemorrhagic type of hypovolemic shock, we are going to give blood or blood products. Then correction of electrolytes and acid base disturbance is to be done in case it is mainly due to the dehydration thing. Then continuous monitoring of vitals, serum electrolytes, then arterial blood gas analysis has to be done along with the general measures if needed, because this will help us to know whether there is any volume overload or not, that is fluid overload is there or not. So these are the 4 steps which are used for the management of hypovolemic shock. Then coming to the next one, that is the cardiogenic shock. So here general measures including BP, pulse, respiratory rate, urinary output monitoring has to be taken. For severe hypotension, we are going to give norepinephrine as IV infusion in 5% dextrose, because there is severe hypotension, and then in that case we are going to give the sympathomimetic drugs, that is the norepinephrine. Then we have to monitor the flow rate of norepinephrine. We can also give inotropic drugs like dobutamine if the cardiac output is low. And suppose if the underlying cause of the cardiogenic shock is myocardial infarction, then in that case we will also give the patient tablet aspirin 325 milligram, that is to be given for this patient, because it is mainly due to myocardial infarction. Then about the anaphylactic shock, as you can see here, so it is basically due to the bee sting which has led to edema and also led to anaphylactic shock. So the general measures has to be taken here also, along with elevation of the lower limbs of the patient. This is because it helps in preventing the pooling of blood. And then we give the drug of choice, that is injection adrenaline, that is 0.3 to 0.5 milligram in 1:1000 solution given intramuscularly, and we can repeat this after 5 minutes if required. Along with this, we can also give the drugs, that is injection hydrocortisone 100 milligram IV, and injection diphenhydramine, that is 25 to 50 milligram is also given along with hydrocortisone. So 3 drugs we are giving, that is injection adrenaline, then we give injection hydrocortisone and injection diphenhydramine in case of anaphylactic shock. Then coming to septic shock management, so here also we have to take the general measures, that is the maintenance of airway, breathing, circulation. Then parenteral empirical antibiotics are to be given only after the blood is collected for culture and sensitivity, and then once we get the results of it, we will shift from the parenteral empirical antibiotics to the specific antibiotics. And if there is hypotension in case of septic shock, then we can give norepinephrine, which are acting as a which is going to act as the vasopressor. And finally, the source of infection, that is, since septic shock is mainly because of the infections, the source of infection has to be identified and the source of infection has to be controlled. So this is basically going to be the definitive management, that is we are controlling the infection, as a result decreasing the sepsis and septic shock. Now coming to the next topic, that is the plasma expander. So we have completed about the different types of shock. So broadly the shock is being divided into four categories, that is hypovolemic shock, then we have cardiogenic shock, then we have obstetric shock, and then we have the distributive shock. So hypovolemic shock, the mainstay of management is basically by giving the intravenous fluids. Then cardiogenic shock, we are going to give the inotropes and vasopressors. Then in case of septic shock, that is which is a type of distributive shock, we are going to give the fluids, and then we are also going to take the further medications which are being discussed already. And then we have this obstetric shock, which is mainly due to some of the obstruction to the flow of blood out of the heart. It can be due to the pericardial tamponade, it can be due to a massive pulmonary embolism. So we have discussed about all the different types of shock and the specific management of the different types of shock, like anaphylactic shock, where the main drug is injection adrenaline, which is given intramuscularly. Along with that, we are also giving hydrocortisone. Then we are having septic shock, where we need to control the infection. Then in case of the endocrine shock, which is because of the acute adrenal insufficiency, there we need to give corticosteroids, because that is what is deficient in case of acute adrenal insufficiency. Now let's discuss about the plasma expanders. So what is plasma expanders? So plasma expanders are nothing but the solutions which are used for temporary maintenance of the blood volume in case of emergency situation, till the point we are getting the blood or the blood products. So this can be either colloids or it can be crystalloids. So colloidal solutions are having a high molecular weight and they exert a high oncotic pressure. That is, the pulling in tendency of the colloidal solutions are more. The pulling in tendency of the colloidal solution is more. So under this we are having following examples, like human albumin, then we have dextran, polyvinyl pyrrolidone, then hitastarch, then we have the degraded gelatin polymer, and then we have the crystalloids, which contain salts and water soluble substance. So crystalloids are nothing but the IV fluids only. So they are the different intravenous fluids which are used in practice normally. So now let's discuss about the requirements of an ideal plasma expander. So what are the requirements of an ideal plasma expander? So the oncotic pressure, that is the pulling in tendency of the plasma expander, then the pH and the viscosity of the plasma expander should be same as that of plasma. Then it should be retained in the circulation for an adequate duration, that is till the time we get the blood or the blood products. Then it should be non-pyrogenic, that is it should not induce fever or anything like that. Then it should be non-antigenic also. Then it should be stable and should be cheap, then only we can afford it. Then it should not interfere with the blood grouping and cross matching, because for the management, that is definite management, we are using the blood and the blood products. So if we are giving any plasma expander, we should give it in such a way that it will not affect the blood grouping process and the cross matching process, so that we can finally progress on to the main treatment, that is the blood and the blood products. So these are the features of an ideal plasma expander. Now let's discuss about the crystalloids, that is nothing but the intravenous fluids. So depending on the osmolarity, it can be divided into the following categories, that is isotonic intravenous fluids, hypotonic intravenous fluids, and hypertonic intravenous fluids. So isotonic intravenous fluids will have the same osmolarity as that of the plasma, and the electrolyte content will be equal to 310 milliequivalent per liter. So under this we are having examples like normal saline and Ringer's lactate solution. Then we have hypotonic intravenous fluids. So they have less osmolarity than plasma, and the electrolyte content will be also less, that is less than 250 milliequivalent per liter. So under this we are having example of half normal saline. Then we have hypertonic intravenous fluids, which has more osmolarity than the plasma, and the electrolyte content is also more, that is more than 375 milliequivalent per liter. So under this we are having example, that is 5% dextrose saline. So these are the different types of crystalloids, that is the different types of intravenous fluids. Now let's discuss this one by one. So first we have the isotonic fluids. So they don't shrink or swell the RBCs. This is because they are having the same osmolarity as that of the plasma. So they are not going to pull in the water, or they are neither going to enter inside the RBC and leading to the swelling. So they are not going to affect the shape of the RBC at all. So 1 liter of isotonic solution increases the plasma volume by 1 by 4 liter, that is 250 ml. This is because it quickly diffuses from the intravascular component to the extravascular component. So whenever we are giving 1 liter of the isotonic fluid, it will lead to increase in the plasma volume by 250 ml, that is 1/4 of the liter. Then patients are to be monitored whenever we are giving the fluids, that is to look for fluid overload whenever we are giving the IV fluids. So examples, we have normal saline, that is 0.9% NaCl. It can be used for the management of hyponatremia and dehydration. Then we have ringer lactate solution, which contains potassium, calcium and sodium chloride. So here the lactate provides the bicarbonate which is used to treat acidosis. So it can be used in the management of dehydration, hyponatremia and to replace the lost gastrointestinal fluids. So these are the two types of isotonic fluids which are used most commonly, that is normal saline and then we have the ringer lactate. Now coming to the next category, that is hypotonic fluids. As you can see here, it is half normal saline, that is 0.45% sodium chloride. So since it is hypotonic in nature, so the fluid will enter into the RBCs, leading to the swelling of the RBCs. And these are used in case of hypernatremia and hyperosmolar condition, because here the tone, that is osmolarity, is decreased. So that's why it is used in hyperosmolar conditions and hypernatremia. So example I have already mentioned, that is 0.45% NaCl, that is half normal saline. We can also give 0.25% NaCl, which is also an example of hypotonic fluid. Now coming to the final category, that is the hypertonic fluids. As you can see here, it is 5% dextrose in saline, that is 5% dextrose in normal saline. So since they are hypertonic in nature, so they are going to pull in water out of the RBCs, leading to shrinking of the RBCs. So they should be injected very slowly in the central veins, because they are hypertonic in nature, so they need to get rapidly diluted. And also this slow administration decreases the chances of fluid overload, because they are having a great tendency to pull in fluid. So slow administration will lead to decrease in the chances of fluid overload. Examples, we are having 5% dextrose in normal saline, then we have 45 to 50% dextrose solution. So these are the examples of hypertonic fluid. Now coming to the next category, so we have completed the crystalloids under the plasma expanders. Now we are going to discuss about the colloids. So under the colloids, we are having the first example, that is human albumin. So human albumin is basically prepared from the pooled human plasma. It is one of the most commonly used plasma expanders. It is used in case of burns, hemorrhages and surgical procedures. The advantage of human albumin is that it doesn't have any risk of transmission of hepatitis B or C virus or HIV infections, but it can cause hypersensitivity reaction, which is an adverse effect of human albumin. Then coming to the next colloid, that is dextran. So it is a water soluble glucose polymer. It is available as dextran 40 and dextran 70 with molecular weights of 40,000 daltons and 70,000 daltons respectively. So dextran 40 and dextran 50 are given as IV infusion of 10% solution and 6% solution respectively. That is, dextran 40 is given as 10% solution and dextran 70 is given as 6% solution. Dextran 40 is having a transient effect, whereas Dextran 70 has got a longer duration of action for doing the plasma expansion. But the problem with Dextran is that they induce the rouleau formation, that is basically the stacks of RBCs. So this will interfere in the blood grouping and cross matching, which is a very important disadvantage of using Dextran as the plasma expander. And they also cause other adverse effects like hypersensitivity, then fever, hypotension and even bronchospasm also. Now coming to next category, that is the next example of colloids, that is Hitastarch. So Hitastarch is basically the brand name for a particular specific formulation of hydroxyethyl starch. So it is derived from starch. From the name only it is clear. It increases the oncotic effect, that is the mechanism of action is just like human albumin, that is it pulls in the water inside the intravascular component, and it has got a long duration of action. Then advantage is that it doesn't interfere with the blood grouping and cross matching, which is unlike Dextran, which actually causes rouleau formation leading to interference in the blood grouping and cross matching. Then the adverse effects which we can see with hydroxyethyl starch includes flu-like syndrome, which is characterized by fever and myalgia, then urticaria, that is itching basically. So these are the side effects which are seen with in the case of Hitastarch. Now finally coming to the last two varieties under the colloids, then we have, that is we have the degraded gelatin polymer and then we have the polyvinyl pyrrolidone. So this is the image of polyvinyl pyrrolidone. So degraded gelatin polymer, it also acts just like human albumin, so it is going to exert the oncotic effect. It doesn't interfere with the blood grouping and cross matching. The adverse effects include hypersensitivity reaction, then bronchospasm, itching, urticaria, and hypotension. Very much similar to what we have discussed earlier. Then we have polyvinyl pyrrolidone, which is a synthetic polymer. It interferes with blood grouping and cross matching just like dextran. Also, it binds with several drugs like penicillin and insulin, and hence it reduces their effect, that is, the effect of these drugs. And these plasma expander, that is polyvinyl pyrrolidone, is nowadays very rarely used. So we need to know that it is a type of plasma expander, but it is not used nowadays that much. Then coming to the different uses of plasma expanders, so as I've already discussed it, so it can be used in case of burns, it can be used in case of hemorrhage, it can be used in case of surgical procedures, severe trauma, and that is still the point when we are getting the blood or the blood products, because that is even better than the plasma expanders. Coming to the contraindications of using plasma expanders, it can be severe anemia. Okay, because already there is decrease in the hemoglobin count, and if we are doing the plasma expansion, it can lead to relative anemia, that is relative decrease in the hemoglobin count. So that's why we are not going to use the plasma expanders in case of severe anemia. Then also in case of bleeding disorders, in case of congestive heart failure, because already the heart is in a failure state, and if we increase the intravascular volume, then it will even further worsen the congestive heart failure. Also, it is not going to be used in case of the patients are having the renal failure. Now, finally coming to the nursing implications of this topic, that is basically the treatment of the shock and the plasma expanders and intravenous fluids. So, early recognition of shock is very important, and it is a key to the effective intervention for the management of shock. Intravenous fluids are crucial in restoring the circulating volume, that is, it is mainly in case of the hypovolemic shock, and careful continuous monitoring prevents the potential complications in case of shock, that is, it can be volume overload or it can be pulmonary edema. So for this we need to do continuous observation. Then we have to assess the vital signs continuously, the mental status and the urine output in case of the shock, that is management of shock. And normal saline is not used for IV infusion of noradrenaline. This is a very important point, as noradrenaline is unstable in normal saline. So normal saline is not used for infusion of noradrenaline, that is norepinephrine, because norepinephrine is unstable in normal saline. So these are the few nursing implications which we need to keep in mind. These are the most important nursing implications in case of management of shock and the use of plasma expanders and IV fluids. So with this, I would like to end this presentation. So these are the references which I have followed. So I hope you like my content, and if you like my content, please do like, share, subscribe, comment, and also press the bell icon so as to get notified whenever I upload a new video. Thank you guys.